about postpartum hemorrhage today, and we define this as a blood loss greater than 500 mLs from a vaginal delivery or greater than 1,000 mLs from a cesarean delivery. So we're going to talk about the reasons why we can have a postpartum hemorrhage and also what our nursing interventions are going to be to address this emergency situation. So our first is our antepartum hemorrhages, which make up 3% of all pregnancies. So for this, we're going to talk about our placenta previa as well as abruptio placenta. So abruptio placenta, just really quickly, is a premature separation of the placenta from the uterine wall prior to the delivery of the baby. Perinatal mortality rate is pretty high, 50%, and it is the #1 cause of a mother going into obstetric DIC or disseminated intravascular coagulopathy. The first one we're going to talk about is a placenta previa, and most placenta previas are diagnosed early on in pregnancy and are monitored by their OBs, but this is where the placenta implants and partially or completely covers the cervical opening. Most moms, if they were to, go into labor or they did not know they were previa, most moms should present with painless bright red vaginal bleeding. This occurs in the 3rd trimester. The goal really here is to delay delivery of the baby until the baby is mature enough without any risk to the mother, so putting mom on bed rest, making sure then that baby is delivered via cesarean prior to mom being able to go into any type of labor. And of course, moms with this condition are at an increased risk for a postpartum hemorrhage after baby is born. So an abruption is, again, it's the premature separation of the placenta. The risk factors for an abruption occurring include hypertension, diabetes, our moms who have more than one baby, so this may be the 3rd baby, the 4th baby, multiple gestations, so twins, triplets are at a higher risk. Moms who smoke cigarettes throughout their pregnancy are at a higher risk. Cocaine and amphetamine abuse during pregnancy are also known to cause this. And then, of course, #1 is typically trauma, some type of trauma that occurs to mother. Alright, so in the case of abruption, this is obviously not something that we're going to, know ahead of time, but mom will present with pain, and most moms have a severe pain. So her uterine tone will be abnormal, so it starts out what we call hypersystole, so almost like a rock hard continuous contraction that does not release and does not go back into resting tone, and then if not diagnosed and if not treated, then mom may start to have tectonic, which are kind of, they're ineffective type of contractions, but again, that uterus is not really working correctly or working the way that it needs to. Vaginal bleeding is not a good indication of an abruption because in a lot of moms, when they have an abruption, they do not have the vaginal bleeding. Maybe, we may see a little bit, but the amount of visible blood is not a good indicator of the amount of bleeding that is occurring with mom. And we have what we call a cuvulaire uterus, which is where the bleeding can occur into the myometrium, which then you get a really, really, really hard uterus, which has problems, contracting back up and going into that involution after delivery. So moms at a higher risk of a hemorrhage after delivery as well. So how do we as nurses address that abruption? #1, we're going to check and assess fetal well-being. We're going to take a look at that baby, make sure baby is doing okay. We want to use an ultrasound to evaluate the placenta itself, location, how intact it is, as well as Doppler flow, indicating blood flow to baby. Fetal heart rate is done on admission. Fetal heart rate is going to occur, every shift if baby is less than 18 weeks, up to 20 weeks, so, under really the age of viability. If baby is, 30 weeks, 32 weeks, then we're doing it non-fetal stress test, and then a biophysical profile weekly. So now we're going to talk about postpartum hemorrhages, and we know that this occurs up to about 10% of all deliveries. 1% of patients will experience a life-threatening hemorrhage of greater than 1,000 ml blood loss. Uterine atony, so the uterus not contracting and that involution not occurring after delivery, is the most common cause of postpartum hemorrhage, and it is the leading cause of maternal morbidity and mortality worldwide. So uterine atony is defined as a soft body uterus, so after baby is born, the uterus just does not return down to nice and firm, starting that involution, returning back to size. We notice heavy vaginal bleeding with clots. Mom will usually say that she's saturating 1 to 2 heads per hour. Risk factors for uterine atony occurring after delivery is a prolonged labor, but also a rapid labor if mommy rapidly goes through labor. The more babies mom has, more pregnancies, so she's a grand multiparity, so greater than 5. Now we're looking at a greater chance of that uterine atony occurring because her uterus has been stretched. Multiple gestations, so twins, triplets, quadruplets, it's because that uterus again has been stretched. Polyhydramnios, so that's where the baby has a lot of fluid around it, and then large fetuses, so really large babies. So what are our interventions for a mom who comes in who's presenting with uterine atony? We're going to follow AWON and ACROG's recommendations. So number 1 is bimanual fundal massage. You can be pictured here. You want to make sure that the bladder is empty, putting in a catheter if you need to, so the uterus can contract. The doctor may order Pitocin IV. Other medications the doctor may consider is Methergin, but we want to avoid that in a hypertensive patient because it can just throw up your blood pressure, make the blood pressure go higher. Same thing with Hemabate. Hemabate needs to be used in caution with patients who are hypertensive. And we want to definitely avoid that in patients who are asthmatics. It's completely contraindicated. Other medications they may consider are Cytotec or tranexamic acid. So, as we're mobilizing our OB to come to see our patient and we're mobilizing help, we can also consider, maybe that the patient needs to be prepared for a back read, balloon placement, or possibly going back to the OR for DNC if that's necessary. Some physicians may like to try to do a leadage suture to try to, stop that bleeding, in the uterus to get that contraction to start down to control the bleeding. They can also try to do an artery ligation again in the OR, and if it's severe enough, they may have to move to a hysterectomy. So in any of these cases, we're thinking about possibly preparing that patient to go back to the OR. So another reason that a patient may have a postpartum hemorrhage is due to retained placenta. So this is when a portion of the placenta does not separate or deliver, as we would have anticipated after the baby is delivered. So this prevents, the uterine from being able to adequately contract down to do that involution process. And really the placenta should be delivered anywhere from about 15 to 30 minutes after the baby is born. Doctors should be looking at it to make sure that all of it has been delivered, so that mom should not have retained placenta. But, if the doctor does need something to help them maybe deliver that placenta, they can consider using the oxytocin, pitocin, or Methergin. So another concern is the placenta accreta. So this is where the placenta grows into the uterine wall, and this prevents the placenta from actually being able to separate after the baby is born. There are 3 types of accreta. So number 1 is just a regular accreta. That's where it's superficially just into the myometrium. This requires the placenta itself to be manually removed. If it's an increta, this means it has grown deep into the myometrium of the uterus, and this typically requires uterine resection to remove the parts that are, actually grown into the uterus itself. And a percreta is where it goes through the myometrium. So now there's no way that they're going to be able to remove that placenta. This requires a full hysterectomy. So placenta accretas, the incidence has been increasing. We think that's possibly due to the increased number of cesarean deliveries that are occurring, so the operative deliveries. Signs of this is delayed or the need for a manual removal of the placenta. An incomplete placenta that's been delivered, so if mom has retained placenta or we're suspicious of it, maybe it is an accreta where it has, grown into the myometrium. Mom will have heavy vaginal bleeding. Large clots can typically be seen. Mom has a boggy uterus that's not responding to massage or medications. And, we can use ultrasound as a definitive confirmation of, retained tissue. The treatment for this is really an emergency D&C and medications, that we've spoken about already to treat that uterine atony. Another cause can be birth canal laceration, so risk factors are large infant, precipitous delivery, prolonged pushing, difficult delivery, operative deliveries. In this case, we see the heavy vaginal bleeding, but we see a firm uterus. Mom may have extreme pain, and really the treatment for this examination and repair under anesthesia. Or mom may have a hematoma that develops after delivery. So again, same risk factors. The difference is that we see a distension of the perineum and signs of cardiovascular decompensation. For this, we really need an exam by the OB as well as excision and drainage done under anesthesia and repair from a. So what signs can we look for in mom to see that she has, hypovolemia due to that blood loss, to that hemorrhage? So mom will have an increasing heart rate. We'll start to notice weak pulses. Mom will start having some increased respirations. We'll start to see pallor. Mom will start to look, very pale. She'll start to get nauseous. Maybe mom starts to get lightheaded. And as it progresses and gets worse, then we'll see a decreased oxygen saturation because now she's losing that blood, not able to get that, oxygenated blood throughout the body. And then, of course, the hypotension from the blood loss. So this slide just kind of gives you an idea of how we rank and we break down our stages of hemorrhage. All of the blood losses that are listed are done in quantitative blood loss, so we're using weighted pads and not just estimating by site. As we talk about and discuss in a few minutes, the interventions that go along with this, we're going to be using the AIM toolkit for the ACOG and A1 on how we're going to approach and how we're going to treat our patient with any of these stages of hemorrhage. And remember that signs of cardiovascular shock will not be present until 20-30% of blood loss, blood volume has occurred. And then following our discussion, we will be doing a simulation, a hands-on exercise to give you an idea of how